Hey everyone, thank you so much for tuning into the Recess Bay. I'm Aaron.
I'm Ash.
And unfortunately, Ashley...
Are you sure? Unfortunately?
Oh.
I can actually get a word in. I'm kind of excited about that concept.
And we don't have to worry about drinks being slung all over the table.
Things aren't thrown at me.
Yeah, exactly.
It's kind of nice.
But as a perfect stand-in, we have Dr. Krebs again.
Hello.
Thank you so much for joining us. And we are so honored today to have as our guest Dr. Ernie Mazzaferri from here at OSU. Dr. Mazzaferri, thank you so much for joining us.
Good morning. Thanks for having me.
And you said before we came on that it's just Ernie.
Ernie's fine.
Just Ernie.
I feel like I'm on Mike and Mike, so that's perfect.
Oh, nice.
Well, that's the way we want it to be, right?
Yeah.
Just we're having a good time. And today we're going to discuss a topic that just seems like it continues to go on. From multiple different facets. And today we're talking about our STEMI patients or our ST elevation MI. And probably I think the reason that this continues so much is because they're a huge portion, a huge segment of our patient population.
They're sick people.
They're sick people.
Yeah.
And I mean, this is kind of my wheelhouse. I love cardiology, and I think the reason is because I can actually do something. My diabetic patients, what I do, I give them some glucose, I give them some dextrose, and I transport them. I can't change their diabetes, but it seems like I can identify in the field that they're having a STEMI, that they're having an MI. I can actually, look to see if they're having a right-sided MI, and then I can make that differential diagnosis, and I can say, maybe withhold the nitro, maybe give a fluid bolus, those kind of things, which really gets me jazzed because I can make a difference.
I actually thought that the opiate toxicity was your favorite intervention.
No.
Yeah, I thought that was like that intervention, getting in there, a little bit of Narcan.
No, that's boring stuff. So, but this is something that everyone's getting into the STEMI business. Hospitals are trying to take care of their local population. So this is something that continues to be on the forefront. So, Dr. Mazzaferri, as one of the big, as we talked about, one of the big populations, I guess you could say, of our listeners is pre-hospital. So I guess maybe start out by saying what should our emphasis be in pre-hospital when we're looking at our STEMI patients? Should it be treatment in the field? Should it be taking them to the local ED? Should it be going to a cath lab? All these different things we hear. So talk to us a little bit.
Frame the question.
Yeah.
Yeah, so that's a good question, Aaron. I'll tell you that I went into cardiology for the same reason you'd like it, is because we get to see a problem, we get to fix it, and it's really rewarding. And so I encourage anybody out there who's listening, spend some time in your cath lab when you take them a STEMI and watch what happens because you're part of the team. So to your question, this starts with the diagnosis, and that's what's changed in our field over the last 10 to 15 years is the diagnosis isn't made by Dr. Ponchel in the ER or me up on the floor. It's made by EMS now, and that has totally changed the way we care for these critically ill patients. So it puts a little bit of pressure on EMS. I have a lot of respect for you because you go into a field not knowing what you're going to get. I sit in the cath lab. I know exactly what I'm getting within some degree of variability. So making the diagnosis in the field, getting a prompt EKG in the field, getting IV access, kind of doing all the ABCs that you're used to doing is key. And once you make the diagnosis, you start with treatment. Maybe you give the aspirin even before you give the EKG, but you get them treatment and you start transporting to a hospital. Get them to the closest possible hospital. Hopefully you're transporting them to a hospital like in the state of Ohio where we have systems of care set up. So if it's a non-PCI hospital, we can arrange direct transport. If they end up at Dr. Krebs' hospital up in Marysville, then we have a system of care set up where I'm on the phone with Dr. Krebs within 2 minutes of arrival, and we've made the determination that we can get them to Ohio State quickly enough for intervention.
See, that's a great point because when all is said and done, it starts in the pre-hospital setting with the visualization of a 12-lead EKG, right? Yep. It's not our 3-lead. Remember that little 3-lead? You used to hit the button and you get that quick little 3-lead and you're like, oh, I know what I have. I have a STEMI. You're like, no. Right. You need that 12-lead, right? So now, Krebs, you do tons of this with Marysville and Union County, and you did actually a bunch of STEMI education. So this is really important, right?
Yes. I mean, our big thing was they let us know in the ER as soon as they have a STEMI, and we can have a transport, whether HEMS or ground, ready to get that person to Dr. Ernie here, Ernie Mazzaferri here,
Ernie.
as quickly as possible in a reasonable time.
But the challenge I always found, and Aaron, you helped me with this, the challenge I always found is So we go through all our training, right? We get these fresh medics in our teams, right? And then the question is, how good are we really at looking at a 12 lead and diagnosing that STEMI?
Well, and that's something I was actually going to ask Ernie. And I think I'm pretty sure I know our answer because
me too.
I'm just going to tell you my thought process. I think we're very good.
Oh yeah,
I think we're very good. I think the education is great out there. I think our monitors are very good at identifying these STEMIs. I think that their differential or their margin of error on these monitors is negligible.
Those algorithms, you mean?
Yeah, the algorithms that are already built into our monitors.
Yeah.
The only thing that I would say, and I think we do a fairly good job, is thinking about maybe our posterior MIs, some of these doing the right-sided 12 leads, like I said, maybe looking a little bit further. And the only other thing that I would say I hope that we educate ourselves on is actually the circulation, the cardiac circulation of the heart. So if I'm showing ST elevation in all of these leads, it's a significant problem because the blockage is up high, But I throw it to you, Ernie. What is your thought process do you have any concerns with EMS bringing you patients on their diagnosis?
Yeah, so I don't, and I'll tell you how this all started. Before 2006, I started in 2005, and that was kind of before this revolution started of door-to-balloon time and Elizabeth Bradley's article in the New England Journal about the 6 ways that you can improve door-to-balloon time. And it started with 2 Columbus Fire EMS in our cath lab in the back hallway who brought us a STEMI patient and were visibly upset. And I thought with me at the time, and I said, what are you so upset about? And they said, because we knew. And I'm like, what do you mean we knew? And they said, we sat in your ER after we knew for half an hour that this patient was having a STEMI.
Oh my God.
Came in here, your team repeated. And it wasn't our ER's fault. This is the way we used to do it, they said. But to me, it always sunk in. They knew. Okay? And so, EMS, you guys know how to read EKGs. And if you're uncomfortable with it, we should be out there giving you the training. And when you know, you know. And even if you're 80% right, that's great. I mean, that's a very acceptable triage rate, and that's about what our number is 70 to 80% accuracy on field activation STEMIs. But when you know in the field, because you've been trained to do this, and you know you have a STEMI, there's no reason to delay. Those patients ought to go directly to the cath lab. So it has really changed the way we do things. It's my favorite kind of case is when somebody in a suburban neighborhood does an EKG in a living room and tells our ER, we're bringing this STEMI and we're coming right to the cath lab. And those patients, truthfully, have somebody come in with an LAD occlusion and leave the hospital with a normal ejection fraction 2 days later or even the next day sometimes. Mm-hmm. Those are by far the most rewarding because that's when we know we did it right. And it starts with EMS.
And I love what you just said, is the concept of going straight to the cath lab. So I want to talk about that a little bit because I used to practice in Tucson, Arizona for a number of years, and I was in a small hospital, and the STEMI would come in through the door. I'd see them. I would have enough time while the cath lab is getting put together and everyone's driving in to actually do a full evaluation, do an echo, see where the wall motion abnormality was. I mean, that's what it was at that institution because we're so small and they were coming in. And when I came here, suddenly I'm barely ever seeing a STEMI in the ED. And it's because our pre-hospital providers are calling it. They're coming to the ED, and they're all they're using my ED door is as a door. They're going through, and they're on their way up to the catheterization laboratory right off the bat. And I love that nature of it. So with that in mind, Ernie, give me a little picture of how that transition happened here.
Yeah.
So again, I'll just make the reminder, it's a class 1 indication on ACC guidelines to get an EKG in the field. Okay, so this is not me as a cardiologist. This is making EMS part of the team, which is true. So, the transition happened that day for us. We walked out of that case, and I said to my boss at the time, I said, this is never going to happen again. We're doing this the wrong way. And that was about the time Elizabeth Bradley's article came out suggesting all the different ways to improve door-to-balloon times. And so we, in collaboration, part of this was the cardiologists giving it up and saying, okay, I don't have to be in charge. And if I get up in the middle of the night and maybe it's not a real STEMI, then so be it. But for the other 8 out of 10 times that it is, we're saving somebody's life. So that was the first step. But then truthfully, the next step was talking to our ED colleagues and saying, are you willing to give it up? Are you willing to accept EMS's word on this? And so And interestingly, our EMS was all for it because it was the right thing to do for our patients. So once that happened, the very next step was, okay, what do we have to do to prepare EMS? Are we doing our part to make sure that they're educated? And so I spent the first 4 years of my career going to, firehouses all over the state. And it was actually, we talk about this all the time. I've done a lot now in my 11 years, but it was the most rewarding time of my career was to go out and meet the people that are actually saving lives in the field.
So the other question I would have, and I know I just jumped on you.
No,
you're
fine.
already
No, you're
so
totally
the other
fine.
question I would have is we have situations where we do have the STEMI stop by, and I love this conversation because it like pieces out this population. It's like, when should they stop? When should they not? So what do you think?
Boy, I have to tell you, I leave a lot of that judgment up to first EMS. Because the providers usually know if they need help. If it's 2 or 3 people and they need help, they'll stop in the ER. Most of the time we're up in the lab, but there are times when EMS, if it's a 5-minute field activation, we're not in the lab. And if the EMS or anybody in the ED feels like they have a very unstable patient that they might need to do something with, whether it be intubation or additional access, whatever it is, then they should do it. Whatever. This whole thing, listen, this is about the patient and whatever the right thing to do with the patient. This isn't about stopping in the ER for a quick look just because we can and just because we need to generate an ID number or whatever the reason may be. This is about doing what's right. And so I always trust our EMS colleagues and our emergency room physicians to make the right decision.
Well, and that's been my experience is that the only time they've ever stopped is for them to say, gosh, this guy, he's starting to sound wetter and wetter, and, he's just breathing so hard. Can you just tube him before we take him up? I mean,
It's perfect.
Yeah.
I mean, what
You don't want somebody coding on the way up to the cath lab because if it's something you could have prevented by stopping in the ER for 5 or 10 minutes. But remember, that's still a pretty small subset of these patients.
Yeah.
That's maybe, again, the 80% rule. That's 2 out of 10 patients at the most where that may happen. The other ones, there shouldn't be any waiting. They should be up on the cath lab. So if it's 2 o'clock in the morning and I walk into the cath lab, my patient's prepped and draped and ready to go, and EMS is standing there giving us reports, showing us the EKG, saying, fix this.
Right.
And again, my favorite thing is when EMS stays and they can be part of it. And I know they're busy and there's times where you got to get back out. But if you can stay and be part of that team, because absolutely you're really the most crucial part of the team.
Well, so I love that because this is something that we set up a number of years ago, is actually getting CEUs for coming to the cath lab and hanging out and actually watching the most, for me, the most significant moment for that patient's outcome. And you actually witness the hard work that you've done in the pre-hospital setting of diagnosis, and you actually see the vessel open, you see the reperfusion. It's pretty amazing.
Well, the one thing I got to say, between those and our stroke patients, our CVA patients, when you bring somebody in with obvious deficits, for instance, with a stroke, and they go in and they do the catheterization, and then that patient instantly is able to use that affected side. And the same with STEMI patients. You can have a patient coming in. Yeah, they're building a house in here.
I know. I was wondering about this.
But, you bring a patient into the cath lab, and they're having 10 over 10 pain, and they're diaphoretic, and they're really hurting. And Dr. Mazzaferri, Ernie, does his thing, and they say, oh, my pain's gone. It is the most rewarding thing in EMS. So I would back that up. I've been there, and I have never had a problem. In fact, most of the times the ED staff or the cath lab staff is saying, hey, come on over here and stay and watch. I can't think, again, of a better educational experience and a more rewarding experience that you leave the ED and you have seen the complete circle from you getting them in their living room to their life being saved and cardiac tissue being saved. It's incredible. So let me ask you one thing I wanted to ask, and I know a lot of people get nervous about making that call to call the STEMI alert. Oh my gosh, I don't want to get, Ernie, Dr. Mazzaferri, I don't want to get him all prepped and then it not be a STEMI. So I'm going to throw you an easy ball here. How often do you really get frustrated and mad at EMS when they call STEMI alert and it's not?
Oh, I guess I'll flip the question back on myself. Am I 100% right on STEMI calls? No way. I mean, it's hard. It's not an easy thing to do. And so the 80-20 rule is a good thing to do. If you're unsure, it's easy. I mean, if you're unsure, you go to the ER and you say to Dr. Pancho or Dr. Krebs, I need some help with this. I'm not sure. It sounds like a STEMI, but the EKG isn't fitting. I go through the same problems. And so a certain amount of over triage is okay.
Right.
But listen, this is about the patients. That conversation I had 11 or 12 years ago now, I knew. I knew it was a STEMI, and you guys made us go to the ER. You were at home. That should never happen.
Well, and I'm a believer, too, in the triaging at the door. It's almost like our pediatric patients. You know, you can look at them, and they're either sick or not sick. And you walk in, and I make mistakes a lot. But when you look at that patient, and they're telling you it feels like an elephant sitting on their chest, and they're gray, and they're diaphoretic, go with your gut.
Yep.
Your gut is usually right. And so what if you make that call and then they get down there and Dr. Panchal or Dr. Krebs and you're standing there, Ernie, and you say, I'm not sure if this is a STEMI, let's watch him. Don't feel bad. You've made the call. Go with your gut, and it's fine.
And we do that occasionally. We'll stop in the ER and say, hey, look, this one isn't a STEMI in the cath lab, sorry, and we'll send them back to the ER, and we just tell EMS, hey, it's okay. I mean,
Right.
and we try and do some education right there at the point of care and say, hey, look, here's why we don't think this is a STEMI, but it happens. If it happened, on every single case they brought to our ER, that would probably not be appropriate.
Well, come on,
it's a rare number.
Right, we do the same thing for trauma. Right?
Exactly.
We give these trauma triage guidelines. We follow the guidelines, but there's always over triage, and we're okay with that because we want to be able to catch the people who are at most risk, and make sure. Now, I want to redirect the conversation just a little bit because this is like one of my little pet peeves. Not pet peeves. It's one of those things that I educate to the most extent I can is our protocol, right? So we talk about protocols. We're talking about catheterization right now, right? So for me, one of the most amazing things is sometimes if we realize that following our protocol actually does change outcomes. So I want to talk a little bit about the old times and when aspirin first came out. Now, Ernie, that's before both of our times. I mean, but the data for aspirin still excites me. Like when I think back that my guys, if they follow my protocol and they give the aspirin, what's the impact of that? I mean,
yeah, basic things are basics, and we always talk about fellows who are learning cath. If you skip the ABCs, you can never learn to read, right? And so following old traditional, data and protocols that we know work has got to be the first step. I mean, once you make the diagnosis, and so things like aspirin and, well, certainly the 12-lead EKG. So you can't forget the basics. If you forget the basics, then your patient's not going to do well and will make mistakes. So.
Yeah, and especially when we think about that old data with aspirin, I mean, we had decrease in outcomes by 40-50% with the treatment of aspirin, and so it's still one of the core foundations of all our guidelines, and everything we do is to make sure we give aspirin and follow those protocols. And actually, one of the other questions that Krebs you had come up with was another protocol thing is what are we supposed to do when it comes to monitoring?
Yeah, and I have a lot of places I work with flight and ground are long transport times, and one of the things we had tried to implement was putting the pads on in case the person develops an arrhythmia, either severe bradycardia or would go into VFib.
Yeah, so monitoring is key. The big issue. So for us, again, one of the first steps we took 10 years ago was, in regards to referring from an outside hospital, and Dr. Krebs at a non-PCI hospital gets these patients is making the right decision. Do you give nobody likes to give thrombolytics anymore, but there's still a time and place for thrombolytics. And so, the first decision we make is, and I was actually on the AHA task force where we decided to go from transfer hospital from 90 minutes to 120. But what that means is the EMS time from EMS eyeballs on the patient to Dr. Krebs' hospital to me, if we can get that blood vessel open within 120 minutes, then we should do primary PCI. So there are times when that transport time can be 90 minutes, and so absolutely they need to be monitored. You need to be ready to treat them. You need to give them heparin. I'll say I don't remember the last time I saw EMS not give aspirin in these patients. I think they almost always do. But then there's times where if the transport time is going to be longer than that EMS to my balloon time of 120 minutes, we should be giving thrombolytics as long as there's no contraindication and the timing is right. But monitoring is a crucial component.
One thing, since we're talking about protocol, and I know this, we've had these discussions with Dr. Panchal somewhat. When we're looking at morphine, the Mona, morphine versus fentanyl. Okay, and we're carrying so many narcotics and things like that, and we've always been told for a long time, well, morphine does all this vasodilation and it's just really going to help, versus fentanyl, which works better for us in the field. I love fentanyl. My go-to narcotic pain reliever is fentanyl. can you lend anything to that? Is the whole morphine, is there evidence to show that, well, we're not really getting the effects from morphine that we thought we were, and fentanyl's okay? Are we just getting rid of the pain so the heart rate's decreased, the cardiac workload is being decreased? What's your thoughts on that?
Oh, I'm going to keep it simple.
Or did I open up just a huge can of worms?
I'm going to keep it simple for you. I just, you have to get the vessel open. You can give them whatever you want, but until you get that vessel open, that's when you're going to change the outcome, is getting that blood vessel open. So I don't think it matters. The one thing I'm really happy to hear is that narcotics in STEMI patients are being used over nitro all the time. Nitro causes hypotension, and you give it to the wrong person, you might have refractory hypotension if they're on phosphodiesterase inhibitors. So morphine, if you look at the ACC guideline, is a class 1 drug in STEMI, and I'm all for it. You don't have to worry about right-sided infarcts. But to me, there may be some differences in how these drugs work, but it doesn't really matter. Fentanyl's easier in the field. I'm totally fine with people getting fentanyl. Ash, I don't know, or Dr. Krebs, if you have a different feeling on that, but either one's fine. Just get the blood vessel open.
Yeah, I totally agree. I mean, there's a couple of studies, even a pre-hospital study, which looked and compared morphine versus fentanyl about safety and efficacy. It's actually a reasonable study. And they looked at it, and the efficacy of using fentanyl in those situations are perfectly fine. And so it's very protocol driven, and that's it. Now, there are some small studies which suggest that there may be some blunting of like the antiplatelet response with the use of morphine. And I don't. To be honest with you, I'm a nuts and bolts type of guy.
Right.
Got to get them to the shop, give them their aspirin, get them in. I think
just
that's,
get the blood vessel open. I mean, the antiplatelet, people can argue and they want to publish and they want to do all this stuff, but get the blood vessel open. We should be focusing on systems of care more than these subtle differences in antiplatelet function between fentanyl and morphine.
So another question: how important is the pain control? How important it is that I try to blunt the patient's pain?
So if it's me, make sure it's blunted. That's a hard question, and you can never. You said it before. When we open these vessels, and it's a team approach. We have a whole team of people.
Right.
I can't do this by myself, including EMS. When we open these vessels, you can see people's shoulders just relax. And so you can give them all the morphine in the world. You can give them all the fentanyl in the world, and unless they're intubated and totally out, you're not going to make them comfortable until you get that blood vessel open. So I always tell EMS, give as much as you need to. Try not to intubate them. If you can keep them off the ventilator, that's a good thing. But give them as much as you need to. And watch your blood pressure, watch your oxygen saturations, and make them as comfortable as you possibly can. I mean, I give the green light and to narcotics in these patients.
So I guess my last question from my seat is, what do you think the future of STEMI is going to be? Obviously, the big focus right now for us is systems of care, getting them in and all that kind of stuff. Is there something coming down the pipe that we should be aware of that is really going to change STEMI management in the next couple of years?
Probably not in the next couple of years. I think prevention is the key. I mean, we hear about the Tim Russerts, and there's all these stories where people had a stress test a month before their MI, and they're unpredictable. These are mini volcanic eruptions because of ruptured plaques inside of a coronary that may have been 40% stenosed, and so prevention and detection is probably going to be the next key. But for what we can control now, and truthfully, I'll take some accountability on this, is we haven't done as good of a job as we could do in developing these true pre-hospital systems of care. We've done, Dr. Krebs can attest, I mean, the way we handle a STEMI from our referring hospitals is way different than it used to be, and it's way better than it used to be. But this is about transport. You got to get people to STEMI hospitals. You can't do PCIs in every single hospital. Almost half the hospitals in Ohio do it, not quite, but you can't do that because not every hospital is equipped to do it. And so we need to work on educating our patients, and we need to work on pre-hospital systems of care.
Do you see any legislation ever coming? So we've got the trauma legislation, where if I have a trauma patient, they have to go to a trauma center. Do you see them trying? Have you ever heard any talk of that, about them actually trying to, if I have indicators that they're having STEMI, that I have to take them to a certain center or something? Is there any discussion?
Yeah, there's been lots of discussion. So we started this 10 years ago with the American Heart Association and a statewide group, and we weren't thinking about legislation. We were just trying to get people to do the right thing. And there's places like Utah and Missouri where they've legislated this, and we've actually talked to them. We brought them to Ohio to discuss this. And, truthfully, if we would all just do the right thing, I don't think we need legislation.
Right, yeah.
But there's a whole new bag of worms that you open when you start putting law behind what we do. And so there's been a little bit of hesitation with that. We've re-engaged EMS recently, state EMS board recently, and I think those conversations need to keep happening. I'm not sure I don't know if you two have opinions about where we should go with this. I have pretty strong feelings about how we should do it. It's a matter of how we get there.
Right.
Yeah. I think the only other last thought that I would love to have here is that we need to also take care of ourselves, right? We have to take care of our pre-hospital providers.
Yeah.
So we hear about this all the time. This happened recently,
Yes.
where we had one of our own guys who had chest pain. We had to drive him in, and middle-aged guy who had to get intervened on. And so we do not talk enough. And I know, Bill, this is a big part of your focus is the wellness of our population of pre-hospital providers. They are the frontliners, but they're always working hard. And let's be honest, our life habits aren't good. I just came off 3 nights, and Ernie was making fun of me. He's like, "Are you taking your melatonin?" I mean, it's like, what are we doing? And so I think one of the concepts for me is really thinking about the wellness of these people.
And just, what you can grab dinner-wise on a busy shift. It's, I'm going to grab a Hot Pocket versus the bag of carrots.
Right. Well, and I think, too, and I'm sure it's the same with emergency emergency department staff, is for some reason, I don't know why, we think we're exempt. We think it won't happen. And I mean, here we have time and time and time again of these suffering people. And we see it. We see what happens to them. And even though Ernie does a great job in the cath lab, there's still very sad outcomes. And so, I mean, I can't think of a time where it's in our face, but we think we're good. We think it's not going to happen to us. And so, you compound our sleep habits due to our shift work and our eating habits because we've missed dinner, so we're just going to run through the drive-thru on the way back from the hospital and all of these things. And then we go from 0 asleep to 100 miles an hour when the tones drop, heart's racing. I mean, when you talk about prevention, we're not always the poster children. We got to start at home. Yeah, we've got to take care of our own house before we start preaching to other people. Absolutely. Well, Dr. Mazzaferri, Ernie, a very humble guy. I am honored to have you here. I would go through his bio. I mean, it's like 3 paragraphs long. But, the one thing that I want to get out there is you can hear how humble he is, and especially here in Central Ohio, and even all of you listening, we're very humbled here at the Recess Bay to have people listening all over the world. If you have questions on this topic, please let us know. Communicate with us. Dr. Mazzaferri, Ernie is always available. We're always available because I think this is a very important decision or important topic. And here in Central Ohio, please, EMS, if you have the availability, just like Ernie said, to stay in the ED or stay in the cath lab and watch that process, it will be a career changing. I don't think that's too strong to say. You actually see the whole process work from their house to actually intervention being done and them being cured. I would say they're cured.
And I'd say one last thing: go in the lab when we're done and say goodbye, and
yes.
You're welcome most
yes.
of the time.
Yeah, absolutely. And I mean, it really is a team approach. So make sure, and then, you know what, even schedule time in the cath lab if you can. You contact your local facility, your cath lab, and put your people in there and let them see what's going on, even if it's not your patient. So, guys, thank you so much for tuning in. Again, Ernie, thank you for your time.
My pleasure. Thanks for having me.
And everyone, until next time, stay safe. Bye-bye.